Okay, so again, welcome everybody and thank you for coming. As Orla said, I'm doing the not real presentation. So I'm just kind of going to give you a bit of information about the Preparing for Life programme, kind of what we've done up to date and some of the most recent results that we've gotten from it. Okay, so just a bit of background about these programmes. So there's a lot of research into the area of early child development, and it shows that children who are growing up at disadvantage tend to have poorer outcomes across a number of domains. So in terms of their social development, their cognitive development and so on, they tend to score lower than their peers, and this can have long-lasting impacts on their later outcomes. So in order to target this, there's been a lot of interventions which have been designed to try to reduce this level of inequality, and these have been shown to be effective in many populations. So generally speaking, they're effective from a biological perspective and an economic perspective. So biologically speaking, most brain development occurs between when the child, or during pregnancy, when the child turns about 3 years old. So clearly intervening during this period is an important time for when the child development, the physical development can be impacted and thus later outcomes changed. Also economic perspectives, so research into early intervention has shown that it can have a good rate of return basically for the investment. So within the US, studies have shown that some interventions which have shown a rate of return for about up to $17 for every $1 which is invested in early childhood interventions. However, most of this research does happen within the US. There's far less research within a European context or even within an Irish context. And clearly the context here is quite different, so the social and cultural context is much different. And we don't really know what works in the US may or may not work over here, so it's very important to research these interventions and see if they are having an impact on children here. Which brings us nicely into the Preparing for Life programme. So I know some of you here probably know quite a bit about the programme already, but others may not know so much about it, so I'm going to kind of go through what the programme is and where it comes from. So Preparing for Life is one of the first and longest running experimental early interventions in Ireland. It's developed by the Northside Partnership and it runs in a highly disadvantaged area in North Dublin. So here we can just see some of the statistics, what the community looks like. Now these come from the census in 2006 and they're compared to a national average from 2006. You can see at the time there was roughly 6,500 people living in the community. About a third were dependent on social welfare. 60% were living in social housing, while almost 50% were lone mothers. Unemployment was high at 16%, and there was a very low level of education, with 66% being early school leavers, and only 5% having a third level education. So as you can see from this, it is an area of high disadvantage, and therefore there is a risk of children having poorer outcomes within this area. So Preparing for Life programme, the bottom-up approach, it was created by the community. So service providers within the community came together to discuss what the community needed in order to meet the needs of the families living there. And so they developed this programme based around their needs. It wasn't given to them by outside agencies, they developed it themselves. And it was based around an evidence of need. So anecdotally, there was evidence within the area that children were starting school not ready for school. They didn't have the skills necessary in order to achieve in school. And then later research kind of confirmed this, that children were scoring significantly below their peers on school readiness skills. So the programme was developed to try and do something about this. So the aim of the programme was to improve the level of school readiness within the area and try to achieve this by working directly with parents to help them to develop the skills within their children that were needed for school. And the programme was based around several psychological frameworks. So these are the frameworks like attachment theory, socio-ecological theory and social learning theory. And then finally for the evaluation, we are evaluating it using a randomised control trial, and then we also have a quasi-experimental aspect to the design as well. So this is what the programme looks like. When parents were joined the programme, when they joined up to it, they were randomly assigned into one or two groups. So there's a high treatment group and a low treatment group. As you can see here, both groups get some of the same supports. So they both got access to public health information. So this involved things like workshops around stress reduction, quitting smoking and so on. They also both got access to a support worker. This is somebody within the area who helps them to access supports which are already there and which are already available to them. And both groups also got €100 worth of developmental toys every year. But in addition to this, the high treatment group also got these two supports here, which are the main supports provided. So that's mentoring and triple P, which I will talk to you a bit about in a minute. In addition to this, we also recruited 99 women from a matched community. So these women were to serve as a comparison group. The idea being that we can use an external group to ensure that there's no contamination between the high treatment and the low treatment group. And also we could use them to just look at the low treatment group and see if that in itself is having any impact on the families. However, today I'm just going to talk to you about the high and the low treatment group. Okay, so what did the high treatment group receive? So the main treatment that they do get is a mentor. So everybody in the family, or everybody in the programme, is assigned to a mentor when they join. And these are people who come out of their home, usually once a fortnight. They would meet with them generally. So meetings kind of go from about half an hour up to about 2 hours, but they average in about an hour. And they work with parents from pregnancy until the child turns 5. So the role of the mentor is kind of to act as a supporter and an advisor to families. They can advise families on key aspects of child development and parenting and help parents to develop their skills in order to help children to develop their skills. And you can see the mentors come from a variety of backgrounds, including education, social care, youth studies, psychology, and early childhood education and care. But they've all received quite intensive training on the PFL manual so that the programme can be administered in quite a standardised way. And then all the home visits are structured around tip sheets. So these are tip sheets which were developed by the programme staff and give key information on various aspects of child development and parenting. And here we just have an example of what some of the tip sheets look like. And I also have a folder here. So this is what the families get. When they join the programme, they basically get an empty folder. And every time then they meet with the mentors, they get a tip sheet, which they can then fill in or add into the folder, and the mentor goes through the tip sheet with them and kind of helps them to understand all the information in there. So the families get to keep these, so they have all this information to hand. Okay, so in addition to the mentor, the families are also offered triple P. So this is positive parenting programme, and it's offered when the child is between 2 and 3 years of age. This is the programme which was developed in Australia with an aim of kind of promoting healthy parenting practices and healthy parent-child attachment. It has been used a lot all around the world. Lots of people have used it, and as such it's been evaluated quite a lot, and it has been shown to have positive effects. So a recent meta-analysis shows that this triple P programme can have positive impacts in terms of parenting and child development. Within Preparing for Life, it's a multi-level intervention. It works from a whole kind of community-based or population-based right down into intensive groups. And in terms of Preparing for Life, people were offered either kind of seminar series, or they could attend group sessions or short individual sessions. Okay, so we'll move on to the evaluation, how we did to find out if Preparing for Life is working. So there's two main aspects to it. We conducted an impact evaluation and an implementation evaluation. So the purpose of the impact evaluation is to find out, does Preparing for Life work? Is it having an impact on parents and families? And then in terms of the implementation evaluation, kind of helps us find out why. So if it's working, why is it working? If it's not working, why not? So to do this, we collected a lot of data. So I suppose the main data collection would be through interviews. We conduct interviews with the parents in their homes 7 times between when they join a pregnancy and when the child starts school, or when the child turns 4. And we gather information on a wide range of outcomes with this. I'll talk to you about them later, but things like parenting, physical child development, health, and so on. We also, when the child is about 4, we do direct assessments with them. So we assess their cognitive skills, their executive functioning, and their delay of gratification. In addition to this, we have physiological data and diaries. We can also link to their administration records, so their hospital records, both at birth and later on. When the children start school, we get their teachers to fill in an assessment of their school readiness skills. And then finally, we also interviewed some of the children after they started school to find out what their experiences were around school. So that last point is something that Alva will be talking to you about later, so she'll give you more information on that. Then in terms of the implementation evaluation, So the main data point here would be the implementation data. This is information that the mentors keep on every communication they have with the participants in the program. So whenever they phone people, whenever they meet them and so on, they keep detailed records in this, kind of how long the meetings went on for. And this kind of helps us to find out how much of the program families are actually receiving. So this is issue of the dosage the families are receiving, and something that Nick will talk about later, so I'll give you more information there. Then we've conducted focus groups with participants. So initially we conducted focus groups with mothers who were taking part in the program, and then more recently we have done it with fathers and father figures. And again, Judy will be talking to you about that later. And then finally we've conducted semi-structured interviews with the program staff. So that's the implementation evaluation. I'm going to talk more about the impact evaluation for the rest of this presentation. So how to join the program? The eligibility criteria is quite simple, really. You could join the program if you were living within the catchment area and you were pregnant between January 2008 and August 2010. And women were recruited through either the maternity hospital or within their local community. So we recruited 233 women from the area, and this represented about 52% of all eligible women. And once women joined the program, they were then randomised into the high treatment or the low treatment group. This resulted in 115 people in the high treatment group and 118 in the low treatment group. Okay, so once the women were randomised into each group, we then conducted a baseline assessment, which we could use to compare the two groups to see if randomisation was successful. And as you can see here, on 92% of the outcomes we looked at, or the measures we looked at, there was no difference between the high treatment and the low treatment group. So this kind of tells us that at the beginning there was no difference between the groups. If we see differences later on, this can be attributed to the effects of the programme. This table also gives an idea about some of the demographics of the sample at baseline. So as you can see, the average age was about 25. About half of them were first-time mothers, while just under 20% were married. About 40% had a low education, and only 3% had gone on to get a primary degree. Unemployment was quite high at 41%, while over half reside in social housing. About 8% had a long-term chronic illness, while about 25% had a mental health condition. Roughly 30% of pregnancies were planned. About half the mothers reported smoking during pregnancy, and about 30% reports that they drank during pregnancy. So as you can see, it is quite a disadvantaged sample, but if you think back to the slide earlier where I talked about the whole area, they are representative of the area in which they live. Okay, so the methodology. So we wanted to test for treatment effects at birth, 6 months, 12 months, 18 months, 24 months, 3 years, 4 years, and school entry. And we measured this across these 8 domains: so child health, child development, parenting, maternal health and well-being, social support, home environment, household factors, and childcare. And so today I'm going to talk about the results at 3 years. So the 36-month results are the most up-to-date results that we have at the minute. I'm not going to go into details talking about the methods that we used, but briefly speaking, as we had a small sample size, we used permutation-based testing to help us deal with this. In addition to this, as you can see, we have multiple outcomes, and this increases the risk of finding effects that aren't really there. So to deal with this, we used a step-down procedure, and then to deal with attrition, we used an inverse probability weighting. Okay, so just a quick talk about attrition. So obviously some people who join the programme will later on go on to drop out of it. Not everybody will continue to the end. So it's going to give some ideas of the numbers. So as you can see, 233 women joined initially, were randomised. And the numbers going to steadily decrease as they go down. Although at 24 months we did manage to claw some people back, but it has reduced slightly again. However, up to about 64% of people have been retained across both groups, and the numbers are quite very similar across both the high treatment and the low treatment group. So as I said, we controlled for this within the analysis, and once we controlled for this, the results that I'm about to present remained robust. Okay, so this table gives a summary of the results at each time point so far. So you can see here, this is each of our outcome variables, and these just give the percentage of outcomes which were significant at that time point. So in terms of child development, you can see at the beginning at 6 months there was no difference on any outcomes at 6 months. However, this continued to increase, so 12 months went up to 7%, 16%, 34%, and then remained stable at about 33%. In terms of child health, again, you see an increase from 10% at 6 months, and it gradually increases. It was quite high at 24 months ago, 47%, and decreases again now to 34% at 36 months. In terms of parenting, we had quite a few differences at 6 months. I don't know what happened here, we didn't find any results at 12 months, but then it kind of stabilised again after that. So, as you can see, generally the number of significant results are increasing as we go on. We use different measures of each outcome at each time point, so you can't really compare directly across time points. But overall, if you look at 6 months, there was significant differences on 14% of the outcomes. At 8% at 12 months, back up to 14% at 18 months. It's increased to 21% at 24 months and up to 22% at 36 months. So they are increasing, we are seeing more outcomes. As I said earlier, we used a step-down procedure to correct for multiple hypothesis testing, and after using this, we found results in 26% of the outcomes at 36 months. Okay, so I'm going to talk to you just about the top 3 results. So these are primary outcome variables, and they're also the ones where most of the results are clustered, so I'll go into more information about these. If you're interested in the home environment, Catherine will be talking to you about that later, so she'll give you more information on those results. Okay, so in terms of child development, so we use a number of different measures to look at child development. First one here is the Ages and Stages questionnaire. So this is a measure that it's parent completed, and it looks at child development in a number of areas, including cognitive development, physical development, social and emotional skills, and so on. And as you can see here, we did find a significant result in terms of problem solving and in terms of the cutoff. So in the high treatment group, about 11% of children were at risk of developing a clinically significant problem in terms of problem solving skills. This is about 22% in the low treatment group. However, there was no significant difference across any of the other domains within the ASQ. We also measured social and emotional development using the ITSE and the VITSE. As you can see, there was no difference across any of the domains here at 36 months. Behaviour was measured using the Child Behaviour Checklist. So this gives us a score for total problems, as well as for externalising problems and internalising problems. We can see here that there were significant differences in terms of their overall score and their level of externalising problems, but again, children in the high treatment group scoring better than those in the low treatment group. And in terms of the total score, this was mainly driven by differences around somatic complaints, sleep problems, aggressive behaviours, and other problems. And finally, some of the measures we used for child development couldn't be put into the step-down procedure. So all the previous results were ones that have been adjusted for the multiple hypothesis testing. These ones couldn't be used analysed in that way. However, we did find that there was a significant difference in terms of the ASQ total score. The DP3, which is the developmental profile, is a measure of cognitive development. So children in the high treatment group were again scoring higher than those in the low treatment group. Okay, so on to child health. So we asked mothers to rate their child health within the last year. We asked across a number of issues. So has the child had an accident, and any health issues they had, and we asked the parent to rate their child's health in general. And here we see that there was a significant difference in that children in the high treatment group were less likely to have an accident or to have spent time in hospital. However, there was no difference across any of the other outcomes there. Then more long term, we asked parents about if their child has a chronic diagnosed illness or physical disability. I found that within the high treatment group, children were less likely to have a chronic illness. In terms of meeting their dietary guidelines, children were more likely to be meeting the guidelines in terms of protein, but there was no difference in the other areas measured there. And then again, looking at the step-down procedure, meeting dietary guidelines again was found to be significantly different. So children in the high treatment group tended to have a healthier diet than those in the low treatment group. There was, however, no difference in terms of height and weight. Okay, then finally parenting. So again, we used a number of different measures to look at parenting styles. So we asked about parenting hassles, so kind of ask how often things happen and how much of a hassle parents find them. We asked for parenting styles, parenting acceptance and rejection. And in terms of these, the only one we found a significant difference in was in terms of the parenting styles. So those in the low treatment group were more likely to have either an authoritarian or a permissive style of parenting. But there was no difference across the daily hassles or the acceptance rejection questionnaire. We also looked at attitudes towards education. So we asked mothers about how important they feel education is. Do they feel it had an impact on their life? Will it have an impact on their child's life? And the only difference we found here was that in the high treatment group, mothers were more likely to believe that education did have an impact on their life and help them to get to where they are in life. And then finally, at 36 months, we also asked parents about their TV habits. So we asked about if they monitor the amount of TV their children can watch, do they put a limit on it, how much time they can spend watching TV, and so on. At this time point, we found that those in the high treatment group, the children were less likely to spend a lot of time watching TV and less likely to spend time watching TV by themselves. Okay, so I've talked to you there about the three main outcome variables. So just going to quickly go through some of the other outcomes that we had, just to give you a summary of the results. So in terms of maternal health and well-being, we found that mothers in the high treatment group generally had better emotional well-being and better mental health. They also consumed less alcohol and were more likely to have reduced their smoking in the last 12 months. Child support was more likely to be paid regularly. The home environment was more likely to be positive, with established routines, safe environment, use of community supports, and more acceptance of child behaviours. And finally, in terms of household factors and SES, but mothers were more likely to report that they were stay-at-home mothers, whereas fathers were more likely to be unemployed. There was an improvement in household finances, but mothers were also likely to be experiencing difficulty with a past or present partner. And then just so I mentioned earlier that we used an adjustment for multiple hypothesis testing. So just here are some of the results which survived this testing, which remained robust afterwards. So there was still a significant difference in terms of the ASQ scores and the child behaviour checklist. Also in terms of maternal and child health, so whether or not the child had a chronic illness and the mother's mental health. And in terms of parenting styles, parents were still more likely to have a more positive parenting style and were less likely to allow the child to watch TV, and it was also a more positive home environment. Okay, so then just where we are now. So as I mentioned earlier, at 36 months we have the largest number of significant results at any time point. So hopefully this will continue into our 48-month results as well. 22% of the outcomes did have significant differences, and these were across the domains of child development, child health, parenting, maternal social support, and household factors and SES, although we didn't find any significant difference in childcare. In general, participants reported that they're very happy with the programme, they enjoy the programme and like it. Engagement is below the prescribed dosage, but it's above 50%, which is pretty good for these programmes. Currently, the oldest child is 7 years old and the youngest child is 54 months. So we've just finished completing the latest round of data collection. So at 4 years of age, we do interviews with the parents and we do direct assessments with the children. We've just collected all this data, so hopefully we'll have the results of that fairly soon. And then the evaluation will continue until all the children start school, and we have school readiness assessments for all of them. Okay, and if you want more information, that's the website for the programme and for the evaluation. And I'd like to thank our funders, and thank you all for listening.